This is your brain. This is drugs. This is your brain on drugs. Any questions? I've got a few. You might be wondering, why is my brain so smooth? There's no edges, there's no ridges, there's none of the curly bits that I've always seen in illustrations. Well, it's because this analogy just doesn't quite work. If this is your brain, this is a drug, this is my breakfast. I remember watching Saturday morning cartoons, and then in between the toy commercials and the really bright color, the Nerf guns, was this commercial that scared the living bejesus out of me.
Is there anyone out there who still isn't clear about what doing drugs does? Okay, last time. This is your brain. This is drugs. This is your brain on drug. Any questions?
If this was my brain and that hot skillet represented drugs and what it could easily do, then you've only got the one chance. The commercial was put up by Partnership for a Drug-Free America. It was a campaign that was trying to end drug use across America altogether by scaring you into thinking that your smooth brain only has one chance to hit that frying pan, and that's it. We now know, after years and years of research, that that analogy doesn't work. We have peer support. We have people that have come out successfully into recovery. We know that recovery is a thing. That commercial makes it seem as if you've got one time to do this and then you're done. Of course, there are more powerful drugs out there. Fentanyl is a huge problem. A lot of people aren't getting a time to even go into recovery because they used the drug the one time and they are dying from that. Not trying to downplay. But there are plenty of people who are in successful recovery right now, and they're doing an amazing job. We've had years and years of quality research done since the 80s, and we now know that so many people are able to go into recovery and have a successful recovery. You can recover. Your brain returns from this to this, back to this. Well, in a somewhat other fashion. So you have your brain scars and such, but you wear like a badge of honor, you recover out loud. I had the opportunity to talk to one of America's standard organizations that treats addiction. The Recovery Centers of America are spread across the U.S., and there's no better way to find out what exactly it is that they do, what they've learned over the past couple of decades, than to have a conversation with them and learn from the experts themselves. So I had the opportunity to talk to two individuals from the Recovery Centers of America to learn exactly what it is that they do. Welcome to Longterm. I'm Ty King, and along the progress of this podcast, it's been an amazing journey and just a huge learning experience. For me as the host, but also for the listeners. Usually, we come in this space of podcasting and creating a show because we feel like we're an expert in something, or we know something that we can supply it to. But I think what we found along the way is that what I assumed to be true because of based on things I'd seen in TV or movies, like those are getting debunked, and recovery itself is just so there's so many different paths that you could take to get recovery. There are so many different things that you need recovery from. There are so many different ways to administer help from that and what somebody needs once they're into the process of recovery. So the best part of this show is being able to talk to the experts and people that deal with this in real life and have the real life experience of helping people come up out of the pits and get their lives together and move forward and produce a really productive life for themselves, their families, their communities. And so I'm excited today to be talking to Dr. Pete Vernig, who serves as the Vice President of Mental Health Services at Recovery Centers of America. And it's a position that he's held for over 3.5 years. And joining Dr. Vernig, we have Dr. Carolyn Thangawng, the State Medical Director for Recovery Centers of America in Maryland. That's a role that she's had since August of last year. Doctors, thank you so much for being here.
Absolutely, Ty. Thank you for having us.
Great to be here.
So I don't even know where to start here. So because collectively, both of you have decades of experience in helping people come out of recovery. So I guess, Dr. Thangawng, you are in Maryland. Dr. Vernig, you are in Pennsylvania, correct?
Yes, that's correct.
Okay, great. So let's start with you, Dr. Vernig. So your position at the Recovery Centers of America, being the Vice President of Mental Health Services, that tells me that if there's a vice president of mental health services of this organization, which we know that Recovery Centers of America, RCA, is just huge and spreads, across the country. The fact that that position exists, it means that mental health is a big need in recovery.
Absolutely. Mental health care has always been central to what we do at RCA and what's done in substance use treatment in general. In my role, I get to support our clinical teams at all of our sites across 7 different states, and really work with the people who are working directly with our patients every day. And it's a very rewarding thing to do.
And so, how did you get into, I guess, a lot of people that are providing services within the recovery realm? Many of them, will tell me their professional backgrounds and will eventually get to a point that would say, oh, but I also have lived experience as well. And that's what really got them into is they received help and they wanted to pay it forward and they built a career off of paying it forward. But that's not your story, right?
No, no. So I'm actually a psychologist by training. I've always, though, throughout my career, been interested in substance use and, really how it sometimes is bifurcated that you'll look at two people who are using together, two people who have similar experiences. One may develop a substance use disorder, one might not. I actually did, when I was working on my doctorate, I did research in this area and looking at what are some of those underlying factors specifically for college students who one may go on to struggle with substance use, another one might not. And after that, I worked in mental health for a very long time, inpatient psychiatric programs. And what really drew me to RCA was the focus on integrating mental health care with treatment for substance use disorders. So really, an organization that recognizes that the trauma and the underlying psychiatric issues, those are one of the things that drive that vicious cycle that so many people talk about when they discuss a substance use disorder. How we can have a wonderful program and we can provide wonderful treatment, and somebody can do so well, but then we send them back into their life and we send them back into all the same contexts, situations. Symptoms that they've been living with before, and if we don't deal with some of those underlying both mental health and contextual issues, really, oftentimes we're setting someone up for failure.
Yep. You mentioned how, substance use disorder, right? And that's something I hadn't really thought of until we started interviewing and talking to people about, their substance use and how some call it a disorder and then some take a different approach and they're just saying this is just, something I dealt with, but it seems like it is absolutely a disorder and it's a recognized disorder. Um, and that includes mental health, but also, Dr. Thangawng, I want to talk to you about your position because also where, Dr. Vernig is taking the mental health approach, you're taking the health approach.
So I actually think that's a kind of a common misconception that, there's sort of these two separate entities and never the path shall meet. But actually, addiction treatment works best when things are used in combination, synergistically. No two people are the same. Each is worthy of a patient-centered, specific, culturally sensitive, personalized, multimodal approach to their care. And so we bring everything together. So I had actually started my career in psychology. I'd gotten a master's degree in psychology, and I worked in research labs involving kids with ADHD and looking at how their brains developed using imaging techniques like diffusion tensor imaging or functional magnetic resonance imaging. And I always had this interest in how the brain develops, how it operates, and specifically how it impacts kind of all levels of a person's life, all areas, all domains. And so with addiction, it's exactly the same. So we think of it as a complex medical illness because, plainly speaking, there is a breakdown in the normal structure and function in the organ called the brain. It is definitely treatable. There's a lot of hope in treatment, but we know that the underlying kind of nature of addiction is this: brain circuits are disrupted. There's a genetic component. People with addiction, many of them come by it honestly. There's a 50% risk of developing addiction among people who carry a genetic load in their family. We can talk about environmental influences as well, but there's a large body of research that looks at adverse childhood experiences and their role in developing addiction. But kind of from a holistic perspective, I think at RCA what makes us unique is we try to bring the wisdom of the field, all aspects of the field together to create really excellence and an evidence-based approach for treating each patient individually.
It's multifaceted where, like I said, there's no cure-all for recovery from substance use issues. I do remember as you were talking, I had flashes on my mind of being in junior high when they would wheel in the table, the TV on the little carts, and then they would show us, the like why you shouldn't do drugs. And some of those were like brain scans of somebody that had been, drinking alcohol for years and years and years, and the effects that it have, and like you would have these big black spots that are damaging your brain. Um, and of course, all the kids around you, you're like, oh, gross, and then I don't want that to happen to me. But some of those very same kids I went to school with, I see them later and I'm like, oh, you, you kind of picked up that habit. So it really wasn't a strong deterrent for you. But yeah, the fact that Recovery Centers of America is approaching recovery from so many different directions and realizing that there's more than just one thing that you need to cover is pretty incredible. And I assume that's why you both landed at recovery centers is because I mean both of you have an extensive resume of working in your respective space, but to land in the same organization, it had to have been impressive to you, or something was calling you, right?
Yeah, I was impressed by the mission. I was impressed by the focus. Really, the organization was originally founded because of the fact that for a long time, if somebody wanted treatment for their substance use disorder, they had a choice between a program that might not really be all that high a quality, that the treatment might not be very good, that unfortunately the environment might even be unpleasant or unwelcoming, or they could fly all the way across the country to Florida or California and go to a private pay program. These are the ones you can find very easily on the internet. There's nothing wrong with that necessarily, but the idea was that you should not have to fly halfway across the country and go tens of thousands of dollars into debt in order to get quality treatment for a medical disorder, for something that is not somebody's fault, that is as Dr. Thangawng said, it's a deficiency in the functioning of the brain. That's not something that somebody should not have right in their neighborhood treatment services available for.
Yeah, similarly, I liked the neighborhood approach. That again, everybody's journey is different, but I really appreciated that it was available right in people's communities. That it wasn't something that people necessarily had to come out of pocket for. That there were insurance options available, and that the environment. I think somebody said it best. It really has this can-do attitude. I think it's a very agile organization. We are focused on the goal, the solution, the next right thing, and I think we really tackle that with some effectiveness. So, for instance, it's one of the few organizations that I know of in the field of addiction that really looks at quality level metrics. So, you can capture numbers around just about anything, but the question is, what numbers are you capturing and why are you capturing them? And at RCA, we really focus on things that are predictors of long-term success in patients. So, for instance, just some examples would be, our patients, do patients each have an aftercare plan that includes interaction with a primary care doctor, that has some kind of safety net involved if things were to fall through, that has contact with the family upon admission or within some period of time, what percentage of MAT and how engaged are they in treatment while they're here. So we really take that seriously. We focused on the evidence, and that's one of the things I really like about RCA is that we really do. Our approach is evidence informed.
The RCOs around here, which are recovery community organizations, like there's 4 in the state of Arkansas. And often they'll have to go if they want funding for a new part of a program, if there's a new house that they're trying to open and a new program that they're trying to start, if it's an opioid, prevention or whatever, they'll have to go in front of these decision makers in law, and they'll want to see evidence-based results. And so, how do you present that? And sometimes it's really, really hard to quantify what is a successful, recovery for someone. I think you named several other things there. Are there any other factors that you look for a successful recovery?
So I would say really a couple things. So we look at recidivism. So does the person have to readmit? We look at quality of life indicators, and we broadly, meaning the field, looks at quality of life indicators, whether the person was able to reduce their risk of using, reduce their harm or harm reduction approach, or whether they were able to maintain some level of relative abstinence. Those are sort of common predictors in the field. And of course, all-cause mortality and overdose and hospitalization.
The mind has a lot to do with that, right? Because you have to kind of make a decision every day to be in recovery, saying that this is what I'm going to do instead of this. And so, Dr. Vernig, what are some of those indicators that you're looking for success in the program?
Absolutely looking for the risk factors that impact that have been shown to be more predictive of somebody experiencing a relapse or return to use. So we're looking at the person's experience of craving. So that would be sort of the other side of that coin that you're talking about, Ty, where that's the part of the brain or the thoughts in the brain or the feelings in the brain that are pulling for not making that decision when they get up in the morning and returning to using or returning to prior patterns of behavior. We're looking at things like engagement with family and recovery support community. Nobody has a substance use disorder in a vacuum, and nobody recovers in a vacuum. Having those sober supports in the community are so critical. Engagement with a meaningful program of treatment, and that's going to look very different for different people. But once they leave one of our inpatient programs, somebody may be on medication for addiction treatment. So FDA approved medications that support their recovery and making sure they stay on those on the longer term, remaining in an aftercare program, engagement with, some people go to 12-step meetings or other sort of mutual support programs in the community. So their ability to stay engaged with those. A lot of these things, and it keeps coming up, and it's very true that it's going to look different for everyone, but that we have these sort of common factors that we know are going to predict that success in the longer term.
You mentioned a few things like the 12-step programs. And so that's before we started learning more about recovery and what that is and how to approach it from all these different levels. My listeners have heard this a million times, but my initial knowledge about recovery came from like 90s sitcoms, right? So somebody in the family all of a sudden is using drugs because of a friend, or they were ended up selling drugs because of the community they were in, and then the family gathers around, they have an intervention. This is, we kill the laugh track, we make this a serious moment. They circle around in the living room and say, "Hey, you've got to get help." They put them in a rehab, and then in 30 days, they're out and they're good. Like they don't ever have to think about it ever again. That's just something that happens, but that's not reality.
Absolutely not. My favorite quote, it's kind of a dated quote, but that I like to use around that is what Winston Churchill said, that, this is not the end. It's not even the beginning of the end. It's maybe the end of the beginning. And that's, if somebody does 10 days or 20 days or 30 days or whatever they need in an inpatient program, when they step down out of that program, that's really just the end of the beginning of their recovery. And it's that sort of long-term support, that long-term treatment, and, just making sure that they have what they need to be successful after they leave. Incidentally, those sitcoms, before I got into the field, probably my first exposure to that as well. So that's where I think most of us have our first exposure to what, unless it's something that has happened in our family, that's a lot of people's first exposure. And for some people, that's their only exposure and their only view of what that's like.
No, exactly. And, that's what we try to help, a little bit playing a role. I know there's a huge tapestry and we're just a thread in that, but trying to give a little bit of information and, pre-training, I guess, because if you've somehow found yourself in this world and you don't know anybody or don't have any connection to anyone that has a substance use issue or ever had one, I don't know how you did it, but I guess congratulations. But inevitably you will. There's something in that's going on in the country where it's a continuous problem, and it's really hard to get away from it. But eventually, you're going to cross paths with someone that has had that issue. So, like you said, if you don't have any,
And if you think you haven't, you have. You just weren't aware of it.
exactly right, yeah, and so people being thrown in that situation where if suddenly your son or your daughter or your brother or your sister or your husband, your wife, your mom, your dad, if somebody suddenly has an issue, like you don't know what to do. What do I do? What I saw in the movies. And so trying to give them better information from experts like yourself is a key part of this. Dr. Thangawng, you said that you were studying some of the brain patterns of ADHD and then move on to people that have been addicted for a while. Have you found anything to help in recovery in your studies?
Yeah. So that kind of gets into the realm of treatment. So to qualify, I had been involved in research a number of years ago, kids with ADHD and autism. Currently, I'm not involved in research, but as an addiction physician, we're always keeping our eyes and ears close to the literature. And the literature is it's pretty clear. I mean, there is hope in recovery, but there is a lot of neurobiological changes that take place in the brain when it is experiencing this substance use disorder, this pattern of addiction. And there's a handful, but we can say collectively, the limbic system, or the part of your brain that's very active when you're experiencing pleasure or strong emotion or involving with habit formation and memory. There's a disconnect between your sort of inner elephant, your inner pleasure center, with the part of your brain that makes kind of wise decisions. Your wise mind, you think of it as your frontal cortex. And so addiction can be thought of as this sort of compulsive search, this compulsive use despite negative consequences, and sort of this loss of control. And a lot of that is neurobiologically based. So if you think of your elephant as your primitive drives for pleasure and reward, and you think of your rider as the part of your brain who's making good decisions and not letting your elephant run away with itself, there is a disconnect. So the frontal lobe, we call this hypofrontality, or the connection is not as strong. And so thinking about what helps. So there's a number of things that, a number of treatment modalities that have shown to be effective in addiction or substance use disorder. One of the research is pretty clear that medications for opioid use disorder like methadone or buprenorphine are now thought of a gold standard of treatment, and should be thought of as a first-line management for opioid use disorder. And the reason is they're pretty clear about reducing mortality, about increasing treatment engagement, about decreasing interaction with healthcare utilization, and also infectious disease spread. But again, it's always the multimodal approach. CBT has also been shown to be very effective as well, cognitive behavioral therapy. But there are a number of therapies that have been emerging as well, and we can certainly talk about those. But I would say the broad four categories would be medication for addiction treatment, behavioral therapy, the increased use of technology like cell phones and computers. CBT comes to mind, for instance, and neuromodulation, which is a field that people are increasingly interested in.
That's incredible. Are you implementing any of those or looking into those as new things that you're offering within the organization?
I would say for certain, we are clearly we're implementing medication for opioid use disorder. We do a lot of behavioral management, including motivational interviewing, cognitive behavioral therapy, both shown to be helpful as well in substance use disorder. But we're always keeping our eyes and ears close to literature, and there have been conversations about various neuromodulatory techniques, but certainly we're forward thinking with respect to those modalities.
Oh no, I would agree. We have always been focused on providing what works. As of a few years ago, we really doubled down on the use of medication for addiction treatment, as it is unambiguous, the literature, as Dr. Thangawng mentioned, and the use of technology and further integrating that into treatment, definitely things that we are investigating and really looking for not only where is the field right now, but where's the field going to be 5 years, 6 years, 7 years down the road.
And so it brings up the question, because obviously, technology has to get better. And I've been to a few behavioral health, conferences recently, and it's very interesting because usually you see the organizations that are providing the resources of like maybe a recovery housing, or somebody that gives you job training, or a place that will get you hired somewhere. But these were specifically CRMs, specifically for recovery organizations, or financial planning groups. But these companies are specifically made for these things that are for recovery. But it made me think about as the technology is, of course, increasingly at a rapid pace, and you just said that you're using more technology. So I would have to ask, does AI play a role at all in the future of recovery or any of the things that you're offering?
So I think AI definitely plays a role in the future of the field. I think it plays a role in the future of a lot of fields. It doesn't currently with what we're offering right now, because I think that as promising as it is, I think the technology is a little unproven currently where it stands. There are newer offerings out there as far as, assistive technology really to support the decision making that clinicians utilize day to day. That's actually nothing that's new. That has existed for years and years. AI is just sort of a new suite of tools to implement that. But in terms of actually as a primary intervention, I've actually demoed a number of tools that are meant for direct person to AI interaction to support recovery. And there's some benefits to that, the constant availability. But of course, there's always going to be some quality issues with that. That if anyone who's used any of the existing AI tools knows, sometimes you get really good responses from it, and sometimes it just really doesn't understand the question that you're asking. It just doesn't really think about it the way that you're thinking about it. And if you're asking for it to make a recommendation for where you should go get dinner, or you're asking it, to help you troubleshoot something when you're making an Excel formula, the consequences of it getting it wrong is pretty low. But if you're putting somebody's recovery in the hands of a tool like that, as with any new tool, we really need to make sure that that tool is consistent and high quality before we be ready to do that. So I think that will absolutely be the case at a certain point in the future. I'm not sure that when we get there.
I echo that statement. So I think it's tempting to kind of look at the newest shiny thing and say that's going to be our silver bullet. That's going to be the revolution of the future. But I think what we have to do is just really be mindful of being responsible with these new modalities. Waiting for the research to demonstrate short and long term efficacy. Right now I think sort of the conventional wisdom is, you stick to what we know works, and we continue to study what's emerging. And what we know works is commitment, engagement, and treatment. So the studies show that about 90 days of treatment engagement really improves outcomes. There was a neat study with the VA in terms of long-term residential treatment versus shorter-term residential treatment, and number of studies that show whether an inpatient residential setting is better than an outpatient setting. And that, these are developing, but the conventional wisdom is get engaged for at least 90 days. Get engaged. We know that if, for instance, doing a detox-only program, now called medically supervised withdrawal, 90% risk of relapsing. So that's not recovery. So, it's a combination of defining what's going to work for that individual person in the long term, as well as what we know to be true based on decades and decades of research.
One of some of the RCOs in where I'm at, in Arkansas, they have recently been asked by DHS, who provides a lot of the funding for their programs, to start using. They have a contract with another company that built an app that they want to use with. They want all the RCOs to use with all of their clients that are in recovery. And it's a pretty basic app, and I just went through the training on it yesterday just to understand it and know what it's like. But it basically tells you, there's a block that tells you how many days clean you've been, how many days in recovery you've been there. And then there's several little things. It's basically a productivity app, but they gamify it where it's like you get points. You can't spend those points on anything. So there's no like ultimate thing that you can do with those. I guess, but it was interesting to me because I had the thought, I was like, oh, you think that they produce dopamine the same way that someone that has never had, substance use issues does. And like, you should just gamify it, where you hear that cha-ching, and you feel like you've accomplished something. I think, that's, our phones have it on nearly absolutely every app that we have, or even our social media. And so there's a reason why they design it that way, because they know what it does in our brain, and it makes us have those little hits of dopamine throughout the day. But and I guess I couldn't have two better experts here to ask, but does the brain of someone who's been in substance use, does it work the same way as those little things, what they're producing in our brains? Is it doing the same thing for them?
I think it's gonna function the same way. I think the salience may be a little bit different. Just that alone isn't going to be enough. But if that provides just a little extra push, the brain does take a lot of things other than substances, kicks in that exact same system. The entire gambling industry is based exactly around that fact and that feature. And even little things that, as you said, you can't spend it. That point isn't worth anything. That cha-ching isn't actual money, or any actual benefit. But even those little gamified minor reinforcers do have an impact. I mean, I have a language learning app on my phone that counts up the days that I've been doing it, and I get a little pleasure out of seeing that number increase every single day that I do it, even though that doesn't give me any actual tangible real world reward. But I think that, to your point, to somebody who has been in that pattern of substance use disorder for a long time, and that part of their brain has really been hijacked by that illness, it's going to have an effect, but so much more beyond that is needed. So, that might provide a little bit of an extra push. And, Dr. Tungman is probably, given the work that she's done, the real expert in that, though.
Well, I mean, I think you nailed it. App-based contingency management or, computer-based contingency management is shown to be effective as an adjunct rather than a primary kind of treatment modality. And that there's something about the live interaction of contingency management. So shaping a behavior with a reward that's tied to recovery. So a classic one would be, patients who participate in a contingency management program might receive, a gift, a kind of a surprise gift inside of like, a fishbowl of items if they have a negative urine, for instance, have a urine that's negative for any substances. So, and there's something about the immediacy of the reward of something tangible given by a human being that's different than CM that's tied to an app. Does it help? I would imagine so. There is some evidence that it is good as an adjunct, but again, not as a primary. And when you're thinking about the amount of dopamine, there's also a magnitude question. So let's just say if I had a golf ball in my hand, the typical amount of dopamine that floats around in our brains on a given day is about a golf ball's worth. And we need dopamine. It's a motivator. It essentially is the brain's way of teaching us to do that thing again, and by making it feel good, we're more likely to repeat it. And dopamine originally, kind of from a primitive perspective, is meant to reinforce behaviors that keep the species alive, like food, eating, drinking water, and procreating. What happens is drugs of abuse will hijack that process. So you're really getting this sort of flood of dopamine that the brain was never really meant to tolerate. And so the brain can become less sensitive, this sort of the idea of downregulation of dopamine receptors. And so when, especially people with opioid use disorder, they have this sort of dopamine depletion early on in recovery. And that's one of the reasons that medications for OUD works so well, because not only does it address the cravings and withdrawal, it also restores that dopamine level. So to get back to your question, a question of magnitude, let's say, for instance, if one golf ball is typical for someone who does not in a pattern of substance use, and 1.5 golf balls is like the best day of your life. You just absolutely nailed it. You came home and, your child graduated valedictorian and there's a Ferrari in your driveway and you just got a huge promotion. Best day of your life. Maybe 2 golf balls, maybe a golf ball and a half to 2 golf balls. But let's take amphetamines for an instance. We're talking about 10 golf balls worth of dopamine. So the magnitude is much greater. Studies have also shown that exercise is really good for increasing dopamine release. Connection to a higher power, having a sense of a community, people that you feel you belong to, and having a purpose. All these things are helpful for regenerating those damaged circuits.
Whole different aspect of recovery, I've never really considered is, yeah, like you said, the brain, the circuits between the brain and right. So the parts of your brain that operate in so many different ways. If they've been damaged through substance use, I mean, how do you recover that? I mean, when you're younger, I guess it's easier because you're producing brain cells, back at a much faster rate. But when you're older, like, so is it possible to make maybe a full recovery, or maybe similar enough to a fully functional brain of somebody that has never done a substance?
So it depends. I think what's clear is that the longer, the longer you're in your substance of choice, the more intense your use is, the route chosen of substance use, for instance, all have these cumulative effects in addition to your baseline genetic vulnerability and what you experienced early on in life. So you think of these sort of cumulative risk factors. You've got, your genetics, which you came into the world with, which you have little control over, no control over really. And we know that genetics is responsible for 50% of the risk of developing a substance use disorder. So you've got that, can't do much about that. And then you've got, if you came to the world with a vulnerability for depression or anxiety and you've got a mental health issue on board, that's another risk factor. Male gender tends to be a risk factor as well for developing substance use disorder. So you've got the fix that you can't do much about, and then you've got your environment. And environment plays a big role on what happens developmentally in a child's life. So, for instance, if the adverse childhood experiences literature, so when kids experience chronic toxic stress that is not a one-hit wonder stress, but goes on and on, and they don't have a protective person in their life to really shield them from that stress and make sense of it, we call these adverse childhood experiences. So, for example, you have sexual abuse, physical abuse, emotional neglect, physical neglect, and then you've got household dysfunction or disruption, for instance, divorce, seeing an incarcerated relative, witnessing domestic violence, substance use in the home. And so you take the environment, you take what you came to the world with, and then you add in the drug itself. So the potency of what we're using. If I were to take like a piece of chocolate cake in front of me and then versus like an 8 ball, what do we think is going to be more addictive? It's kind of obvious, right? So the thing itself counts, and then how you use it counts. So if I smoke something, it's going to get to my brain a lot faster than if I were to ingest it orally. Same thing, same kind of principle applies with IV use. And then the last major kind of piece of this puzzle is the age of first use. The studies are really clear that using any kind of substance during your adolescent years is a big risk factor for developing addiction later on in life. And that's because these sort of, the frontal cortex, that wise mind, your rider on top of the elephant, develops all the way to age 24. And it's one of those things that it's sort of, it really does impact a child's development. They're much more likely to go into developing addiction if they've had use at an early age. And putting all those together, you have, now, how heavy am I using? How often am I using? What's my behavior around this addiction? And so you can't always reverse what's been done. The studies are clear on that. But we do know that there is some restoration with time. It's difficult to quantify, but the brain is plastic. It's a neuroplastic organ. It responded to the change with the substance. It's going to respond to the change without the substance. And what's clear is that when people adopt kind of a medical model to this condition and take the medication for addiction and get some education on your condition and get a support group and do all the things, you're more likely to stay in recovery. You're less likely to kind of fall back on old ways, in a manner of speaking.
That was the most informative way I've ever heard that put. But yes, it's incredible. It's a lot of information. And yeah, a very sophisticated way of saying what I've heard from other people who have talked about it. But like you're putting the I guess the scientific mind behind it. But people tell you in recovery, oh, you got to change your places, the people you're with,
People, places, and things. Yeah.
sophisticated, complicated part of that. But yeah, it makes so much sense. Yeah, thank you for explaining that. Makes so much more sense that way. And I know I reached out to you and about the future of recovery. So I do want to get your take before we end this about where do you think the recovery, because it is an industry, right? So recovery covers a broad category of things that are across the U.S. and everything from nonprofit organizations to church groups to, people that are hosting, celebrate recoveries and in a small building or a shed, to the big rehabs and organizations like recovery centers. Where do you think the future of recovery is headed? I'll start with you, Dr. Vernig.
I think, three areas that I would highlight for that. The first one, of course, being technology, and we've kind of already talked about that, but the further integration of technology into the recovery process, not just because it's a shiny new thing, but things that have actually been shown to be successful. Dr. Tungwan talked a little bit about contingency management and some of the available programs for in that area. So I think technology is a big piece. The furthering of uh, medical interventions. So new drugs that are able to have greater effect than the current medication that's given. Currently, there's FDA-approved medications for alcohol use disorder and opioid use disorder, but really newer, better medications and other medical treatments. Talked a little bit about neuromodulation that would work for that. But I think that another big piece is, as you talked about the substance use treatment industry, no longer looking at substance use disorder in an episodic manner. And what I mean by that is, and there's a lot of reasons why this is the case, not the least of which being the way that traditionally insurance companies and payers have reimbursed for substance use services. It's looked at something as episodic. So a person has the illness, they're admitted into a program, they receive treatment, they discharge from the program. That's an episode of care. They may have another episode of care in the future. That's what we refer to as a readmission to the program. But instead of looking at it that way, really acknowledging what we've already discussed, which is the fact that that's only the very beginning. And even if a person does have an increase in their use or return to use in the future, looking at this from a population health management or longitudinal standpoint. So, really, in between those episodes, what care does somebody need? And treating it more like what we've been saying it was since I think the 70s or 80s, a uh, relapsing chronic illness, and treating it as such instead of treating it as somebody like if you were to have a broken bone, you're going to go to the hospital or to a doctor's office, you're going to have the appropriate treatment, hopefully it's going to heal, and then you're going to move on from that, and then that basically episode is over. So but instead treating it like something like cancer or hypertension or diabetes, things that absolutely you can recover from, absolutely do not have to define your life, and that you can live a full and happy rest of your life with that, but that's always going to need to be managed.
Yeah, well said. Yeah, I agree. I think the field is also really, it has to evolve. I think historically people are maybe they get loyal to their own kind of path in recovery, to the exclusion of others who may take a different path. So I think stigma reduction is going to continue to evolve. That's an important area. I think harm reduction as well. So we know from a kind of a public health perspective that social determinants of health are different for different communities, and they make it more or less difficult to access care that's quality care. And so a harm reduction approach might say, well, instead of, kind of having people walk through the eye of a needle to get treatment, let's make treatment available everywhere. Let's let there be no wrong door to having treatment. And so, for example, that would be in jails, for instance, making, and Maryland has enacted some legislature around this, that now all jails are required to offer all forms of medication for opioid use disorder inside of their walls. And so, finding people where they are, the lowest possible barrier. Also, emergency rooms is a great place to implement low barrier treatment. And similarly, in Maryland, there are many emergency rooms who treat with buprenorphine in the ED, some methadone, but that's another evolving area. And we really need to destigmatize this disease in healthcare. So not only in the rooms of AA and NA, but in healthcare as well. And then finally, I think we have an adolescent population that is in trouble. The kids are not all right. And I think that's a very important area of addiction that we need to focus on. I mean, the vaping industry, kids are 4 times as likely to become smokers when they're exposed to vaping early on in life. We have a rising stimulant use disorder problem. So I think the future is in focusing on harm reduction, on the kids, no wrong door to treatment, And I think there's going to be, so semaglutide is a new medication that shows a lot of promise for potentially multiple substances. And then again, I think stigma reduction is really important too. And there'll be neuromodulatory techniques that, they'll come, but I think the heart and soul is going to be kind of the things that we've discussed already.
Do you think that we're on a clear path towards those being more readily available or readily used?
I think in certain places in the country, yes, and in others, no. I also think that, with the current administration, policy shifts and their impact. So, like the good news, for instance, would be SAMHSA. They made a lot of changes on sort of reducing barriers for people to receive access to methadone, for instance. So opioid treatment programs are highly federally regulated entities that provide methadone and buprenorphine. But typically, they can be challenging to be admitted, to stay. You have to earn your take homes, and so there have been a lot of barriers. But SAMHSA acknowledged that, and they've reduced a lot of those barriers to treatment. So there are entities out there that are seeing this and doing something about it, making it easier for people. But, if there's no research money to look at this from a population perspective, if CDC's health data, is being removed, if there's if there's freezes on federal grants to continue to research addiction and recovery, then our future is potentially in jeopardy in terms of innovation.
Local organizations around me who I know that they've had their funding pulled because they were operating off of, DHS grants, but it was from around COVID time. But realizing that COVID had an effect on people that were in recovery, where a lot of people relapsed because you weren't getting social interaction. You couldn't go to those recovery groups where you were getting all that support. And so anyways, they were using more funds towards, getting those groups together, whether virtual or whatever tools they needed to use. But they said because it didn't have a direct effect from COVID, that was being, taken back. And so, yeah, having to figure out new ways of approaching that. So it just shows to me that there's a huge misunderstanding of like how this all works. And I would hope that in the future, like you said, the stigma about it and more educational resources, more tools that are available, and that we're not assuming things that we don't know and we haven't tested, Listen to the experts. That's why we're doing this. We're listening to you because you're the experts on this. And so we need more people to do that. Absolutely.
Well, I think what people oftentimes don't understand about that is stigma isn't just something that's unpleasant. Stigma is actually dangerous. Stigma stops people from getting the help they need. Stigma stops people from reaching out. Stigma stops people from asking for support and really getting the word out there, talking about it, having open conversations about substance use disorder like we're having right now, publicizing it. That's what's really necessary because as we had said, everyone's met someone, whether they know it or not, who has struggled with substance use and with mental health. And for us to be able to talk about it as a society, for us to be able to support each other and just be there for somebody when they're in need, that's really what's needed.
Thank you so much for spending your time here and, giving your knowledge. I mean, this is something that, I think it's really, really important that we don't gatekeep, what we're learning along the way in recovery. And it helps in doing all those things that we've already talked about and addressed so many times about the future of recovery and helping people, helping your neighbor, helping your family member, helping somebody that that is, obviously struggling with something. This is something that, I mean, Dr. Thangawng, you mentioned earlier how it just changes your brain. This is not something that's just something you turn off one day. You don't just wake up and flip the switch. So it takes time, it takes many resources, it takes tools. And yeah, I'm so grateful for people like you who are doing the work that I think gets kind of overlooked and people don't recognize of the effect that you're having on the community. And so thank you both for what you're doing. If people want to find out more about the work that you're doing, where might they go online?
So they can go to our website, recoverycentersofamerica.com. If somebody would like to talk to someone, whether they are struggling with substance use disorder themselves, or maybe they have a friend or family member who they're concerned about and want to learn about treatment options or just what they can do to support them, we have a phone number, 1-800-RECOVERY, which is staffed around the clock. So anyone who is interested in information, they're welcome to try either of those sources. You can also chat with somebody on our website, and whether it's about you, whether it's about someone else, or you're just looking to get information, resources are out there.
Yeah, it's all part of the RCA family. So we have 11 sites, if my last count is correct, spread across the eastern seaboard. And yeah, we offer all levels of care. So the continuum from sort of medically supervised withdrawal, formerly known as detox, 28-day residential. We offer outpatient programs that are very structured. And we have a really strong alumni community, really who have walked in this illness, who have overcome, who are overcoming every day, many of whom come back and even work with us. So don't be shy.
And 1-800-RECOVERY is an easy enough number to remember. I think everyone can put that one to memory. So yeah, thank you both so much. And thank you for listening. If you're watching this on YouTube, you can find this in audio podcast platform from Spotify, Apple, iHearts, wherever you find your podcast that you like to listen to. Choose your platform, and vice versa. If you're listening to this as an audio podcast, then you can find us on YouTube. The main ask here is not just to subscribe or to comment. The purpose and the ask here is that if you heard Dr. Vernig, Dr. Thangawng, say something here that was impactful to you, or if you thought of someone of like, oh, I really know who needs to hear this, share this episode with them, because that's the most important part, is getting that information to the people that need that information. And you never know. I mean, the worst thing they can do is not listen to it. The best they can do is they listen to it and it changes their life. And so there's nothing to lose here. It helps get the information out and accomplishes all those things that we talked about and how we can have an effect on the future of recovery itself, and have more empathy for people that are around us. And so I appreciate everyone for being here, and we will catch you in the next episode.